Yeah, I'm about to repeat it. So she said, where does sleep deprivation fall into the category of impairment? I think where it falls into, with the AMA, particularly with the Federation of State Medical Boards, is if you are cognitively impaired for any reason, they don't necessarily specify. They say, yes, if it's these things also, and you believe that it could be posing a patient safety risk, they're impaired. Now, this is going to be a quick and easy evaluation and investigation, hopefully, and maybe it is just sleep impairment or sleep deprivation, but maybe they're sleep deprived because of something else. And this is exactly the kind of thing that people will look at and say, they just didn't get enough sleep. They're busy. I know they're doing a lot of things. And you've missed an important symptom. So they won't specifically specify that and define that as a source of impairment, but they've intentionally made those definitions very broad so that when you see impairment, you don't have to qualify it. That appears to be impairment, and I'm going to sort it out later. I'm going to pull that person off the schedule and make sure they're okay. And I think that's what their intention is. And there are probably many other areas or many other things that would cause impairment, short-term or long-term, that may not be clearly defined in those definitions. But very good question. I'm glad you asked it.
Hey, thanks. Who do you want to direct it to? Dr. Clower. You're up, dude.
Yeah, that's a great question. So if you become aware that one of your providers got a DUI, but they didn't show up for a shift, they're not intoxicated now. Let's say it happened a week ago, they were on vacation, now they're back for their shift. What do you do, if anything? Well, when you look at, and we only had limited time, but that is clearly defined in the Federation of State Medical Boards definitions, that if you become aware of a potential substance abuse issue, and this would be an exact example of that, you become aware that someone had a DUI, that's aberrant behavior. And I think you can assume, until proven otherwise, that that could be a substance dependence issue and it needs to be evaluated. So I would say the direct answer to your question is, once you become aware of it, you go through that same process. Even though they didn't show that impairment in the department, that judgment could also cross over into a patient care area, and it's not acceptable. Does that answer your question?
So you keep them on the schedule?
I wouldn't. I'd pull them off the schedule until you sort it out. I'd expedite this, get it done as quickly as you can. But the problem is, if you've been made aware, she asked if you'd keep them on the schedule. If you become aware, and now the next time they come in, with all the stress of this going on, now is the time they come in, you knew about it, and you knew it was a potential risk, even if it was a small risk. So I think you have to be as responsible as you can, acting on the patient's behalf, and that will always protect you. If there's no risk to the patient, you do not need to do anything. If you feel that there's some risk, that's unacceptable if you're aware of it. Okay.
Another question?
Could I add to that?
Yeah, perfect.
I would recommend your local medical staff advisory person on this get involved in those kind of cases. Unfortunately, this happens, and a lot of times that person splashed on TV with the police cam video in local markets. And oftentimes the medical staff has an authoritative source. Realize this happens more frequently in other disciplines than in emergency medicine, and they probably have some good experience to contribute to something like that.
Another hand? Okay, hey, I got a new methodology. You can ask your own question.
Tim, one of the things you left out was, what do you do with the no-pay patient and EMTALA stabilization and treatment before you send them to the local hospital who's now mad at you because you are taking the cream of the crop?
So we don't really do EMTALA stabilization. We just take care of them if they need to be taken care of. If they get transferred to a hospital, it's because they need hospitalization. So that's kind of a wash. The hospitals never whine. 90% of the patients that are sent from freestandings to them are funded, and you have to take the good with the bad. They only get one chance at that, so that never enters their mind. So, you take care of a lot of stuff for free. I mean, this was a lot less than we used to take care of for free, and we don't mind taking care of sick people.
Yeah, to go along with that question, actually, do you guys do a Medicare opt-out? because at least in the family medicine realm and a lot of other areas, if you don't do an official opt-out through your Medicare provider, your regional group, then you actually are breaking the law by non-charging of Medicare.
No, we don't do an opt-out. We don't charge the patient, nor do we charge Medicare. So there's a difference between the opt-out charging the patient versus charging Medicare. If you're going to charge the patient, if that's your intention, then you have to do an opt-out and then charge them. If you don't intend to charge them at all or Medicare, then that's not necessary.
I believe that's false.
Okay.
I believe that if you have to have somebody sign a waiver to receive free care. There's a specific CMS regulation, and I believe this to be the case. I was trying to set up a cash practice for my spouse, paying attention to that pretty heavily. And I think you actually can't provide free care to a Medicare person without being in violation of something.
So we have a bank of lawyers that figured this out, and there are a number of the ER freestandings that do an opt-out and have the patient pay cash. So I'll look into that for sure, but our attorneys say that we're doing it the best way. We also have a question into the OIG regarding this exactly. It takes them months and months to answer, but so we'll get a clarity.
Tim, this is an easy one. Are you open 24 hours a day?
Absolutely. Yeah, you have to be.
Okay.
Thank you. Jim, this is a question for you. You talked a little bit before on the data collaborative on the decision to admit. When I talk to our individual docs, we're still all over the map. For example, if the MICU asks you to try and wean somebody off on BiPAP, the two-part question is, what should that look like as a consistent definition?
And let me be very clear, there is no consistent definition. CMS has written a gray definition. They've written a gray definition because the IT product suppliers to the industry have said that they don't have a consistent way of reporting it, and particularly smaller hospitals have no particular way of reporting this because they don't have the IT backup. So for now, all of you know who are Benchmarking Alliance members, we asked you, open-ended question, what is your definition of decision to admit? Some of it was based on an emergency physician's decision. Some of it is based on an admitting physician's decision and trigger. Some of it was based on the bed czar. Some of it was based on bed assignment, et cetera. So we don't have a consistent definition. CMS right now is not going to press any harder on that issue. And our different IT vendors with the big names have said that they're not going to come up with a consistent definition within their industry. I'm sorry. The front end number for boarding time is a gray area. The back end is physically the patient's leaving the emergency department. So that's where we are right now.
The second part of that question, though, is describe the calculation. Please describe the calculation for boarding time, which was left off my hospital dashboard, curiously.
Yeah, I'm curious. I don't understand that. So the definition is from time a decision is made to admit until patient physically leaves the emergency department. That is the definition from CMS and that we have developed in our work.
Yeah, and that was, when we had at the summit, that was actually my group, and we had people from around the country, people you all know, and we sat down and we asked everyone what definition they used for decision to admit, and everyone had a different definition. And you had to call the hospital, so you got to admit on your own. And the easiest one is you walk in the room, it's Sherry's blink decision. 52-year-old male, crushing substernal chest pain, risk factors, pale diaphoretic. Your decision to admit is right then, okay? But you can't really admit them because you still have to wait for the EKG, you have to wait for the troponin, and you have to wait to talk to somebody, you have to wait for a bed. So where along that continuum was it? And we went around and around for a couple of hours, maybe even overnight. And it was expedient. The only way we could say that we could genuinely make it consistent across the entire country and have a timestamp that was reliable and reproducible, the decision to admit became the time that we actually enter an admit order. And so that's the way we've defined it. And then the second part about boarding time, I've sat in representing the specialty in meetings all over. Is it 1 hour, 2 hours? What is it? And this actually came out of the academic chairs. Boarding time starts the minute that admit order goes in. So instead of saying boarding is whatever, after a period of time, it's the total length. And the goal would be that you should have a boarding time, median time of about 30 minutes or 15 minutes. You want to have 90% of your people out of the ED within 30 to 60 minutes, and that's your boarding time goal. Now realize, lots of places it's 2 or 3 days, but the only way to get to where you want is to start at time 0.
When you say admission order, do you really mean admission order or bed request? Because they're uncoupled at many places.
We talked about that as well. It's when the emergency physician, and this is, I think, rather elegantly worded in the document. You can pull it up. It's free on the Academic Emergency Medicine website. It says, when the emergency physician or provider begins the admission process, whichever one's first, the bed request, the consult time, the admission order, whichever one it is in your institution, because we all have it different ways. But when you're finished with the ED portion of it, everything you need to do to get to that point, and you can start the process, bang, that starts the boarding time, and that's your decision to admit. And again, we realized that that wasn't going to work. We're hoping that as software gets better, as this gets more clarified over time, that we could have a more precise decision to admit definition. But in 2014, when we did this, we were all over the board. The only way to be expeditious and get something out there, and that's what we did. So.
We put something that's searchable into our chart that says we want to admit this patient, but if they order a PE study or they order a blood gas or something else, they don't want us to put the bed request in. So what we've done is we've got a workaround with a statement that says this patient's being admitted regardless of the results of the study. And so when we put the bed request, we're able to search back and get better numbers.
Yeah, and David, ideally that would be great, because there is a period of time when we know we're going to admit the patient, and then we are asked to wean them off the ventilator, we're asked to do all kinds of things, and that should not count against us. But because that changes from Connecticut to Rhode Island to all those other New England states that don't matter for Texans, the only thing that was consistent is when you begin the admission process. And so if you're stuck doing a PE workup or something where you can't do that, that time's on you, unfortunately, for now.
So when you have a very long length of stay and significant boarding time, is there any more elegant metric for nurse staffing than a straight ratio, just because it will suck down our patient seen per hour by the nurse to a laughable level?
Don't have an answer for that. I'm sorry. And I know ENA, and for the nurses in here, you probably know ENA produces different numerical depictions of nurse staffing. And I know, working with our nursing leadership in hospitals where I have been, there's significant discordance in how they credit worked hours when an admitted patient's in the emergency department. So if you will, the patient who's down there, the revenue is being credited upstairs while the work is being done down here. And the nurse managers in many emergency departments are trying to find something better to reflect that. And I'm sorry you're in one of those places where that affects you significantly in your operations.
Well, one of the intended side effects of starting boarding time from the minute the admission order is, you can now quantitate how much boarding time you do. Okay, the admission order goes in, now you're an inpatient. You can add up those minutes and start deciding how much inpatient care you're doing in your ED. And it's really amazing because, at times I can't admit someone to, a medicine floor because they have a surgical problem. I have to wait for the surgery specialist nurses to be available. Well, what's it with our ED nurses who are specialists in emergency care, yet they're doing inpatient stuff? So you can start to quantify that and bring that back to people and see how much of your time is used up doing that way. I'll give you an example. Back about 10 years ago, Sandy Schneider called herself the Queen of Boarding. The University of Rochester, where she was at the time, was light years ahead of us in terms of the total number of inpatients boarded in the ED. At one point, she claimed that she had the second largest inpatient service in the state of New York in her ED. And she had more boarders than she had actual beds. And I think if you get to that point where you quantitate how much time you're doing giving inpatient care, you have a very compelling argument that you're giving more than some of the floors upstairs. You need staffing to do that.
Okay, this would have been for Mike. I don't see him. So it's a billing and coding question. So I guess anybody can answer it. We have EM residents and PAs working in our main ED. So my question is, when a PA is seeing a patient that turns out to be critical, I get involved. They're charting. There's times that the PA is doing the critical care documentation. I'm doing a lengthy attestation. I might be doing the intubation. I just wanted to see it regarding reimbursement. And then the other issue is if the PA sees someone that comes in with hip pain, it's a hip dislocation, they're documenting it, but I'm doing the procedure, so they're just documenting it for me, and I'm doing my attestation. Sounds like we should change the way we're doing things. So I just wanted to get your input.
All right, I'll do my best, and I think I'm fairly familiar with this topic. So your first question is, when you have a shared service with a lot of commercial payers, but definitely with Medicare, a shared service, you have to have face-to-face time with the doc to bill at 100% the physician fee schedule. So you have to be there. If not, then you're going to bill. You can only bill at 85% the physician fee schedule. So that's a difference there. A lot of commercial payers, they don't require that face-to-face time and the documentation that supports you at the bedside, but you have to sort that out. But certainly for Medicare that they do. Now regarding critical care time, that jumped out at me when you mentioned that because generally speaking, based on CPT guidelines, and I hate this term because I think our PAs and our advanced practice nurses are a great addition to our workforce and a wonderful part of our workforce, but CMS hasn't moved along with their terminology. They call them non-physician providers, NPPs. NPPs aren't supposed to be able to claim critical care time. So now there are some exceptions. I think California may be one where there are some with Medi-Cal or someone like that where that may be possible. But from CMS's perspective, the last ruling I read on that, they can't. So there's certain procedures they can't do. Now, if you are doing your hip reduction, as you said, but the PA is documenting a certain portion of the chart, and you are billing for the procedure for the hip reduction, that's going to be billed out 100% the physician fee schedule because the physician's NPI was used. When you have the physician assistant do it, and if it is one of those carriers that is going to require face-to-face time and you didn't provide it, you maybe talked to the PA, but you did not do anything directly with the patient, that's going to be 85%, no matter what procedure you are billing for. Because remember, E&M levels of service are procedures. That's what they're looking at. It's a service. We're billing for services. The hip fracture, just like a level 4, those are all services we're filing a claim for. And so I don't know that you have to do anything different, but I think you probably need to look at how you're doing it and making sure that it's comporting with the commercial payers and CMS. And the default position would be, if you're not certain, go with what CMS states you should do. Does that help at all? Okay, good, perfect.
So this is a question back to the benchmarks. At my organization, we follow and we compare ourselves to the California average, and we're better than average, although it's an easy comp. So the question is, where do I find actual best practice timeframes? So that if our ED throughput is 20 minutes better than California, but it's honestly about 80 minutes worse than Kansas because those guys are good. Then how can I go ahead and find an actual standard that I can present to the board to say, look, these are the things that we need to work on, a 30 to 50, 60-minute standard or something like that?
Okay. I have to admit we have the wrong name because we do not do benchmarking. And the reason we don't do benchmarking, in 1994, benchmarking used to be a good thing to do. And as we've gone through the years, benchmarking in our industry has become something that normal people don't do. People who do benchmarking or come to you with benchmarking typically have something to sell you, and we're not selling anything. So what we offer to groups like yours or anybody else who participates is a cohort set that we have created, or a spreadsheet of material that with the hospital names blinded, so that you can pick your own cohort group. And if you look through your cohorts and decide that there's a practice you'd like to emulate, there's the opportunity to share information with a hospital that has similar practices that you would like to find. So benchmarking, if we had a chance, we would not name our group the Benchmarking Alliance, because benchmarking, now you all know, you get data from some consulting firm who says we've got benchmarks for you, and all that is we want to sell you something. We don't have anything to sell. Number two, in setting up anything that you would want to look and compare to yourself, you may be a 60,000 volume site in urban California. You would like to have a set of cohorts of 60,000 sites, and maybe you want to use California sites, maybe you want to use anything west of the Mississippi sites, maybe you want to use any 60,000 site, find out what they're doing well, how they're processing well, how they're staffing well, how their door-to-physician times are low, et cetera. So that's the opportunity to do. We don't tell you what that is. Fair enough? Thank you.
So my question actually is kind of back to Kevin and to the whole group really, but anecdotally, now that we have places where federal laws are ignored and people can participate in use of marijuana, have you heard of anyone being impaired as a result of marijuana in the workforce?
That is a great question. So he's asked about, you probably heard about it, I don't know if you heard him all the way in the back. So what do we do with impairment in marijuana? You know, I struggle with this even just from just from a legalization and decriminalization standpoint that, you know, at least we can blow an alcohol level, right? And you know at the roadside if somebody's impaired or not. What do we do just from a safety standpoint, public health safety standpoint? I don't know. And that crosses over to work. So I think what happens is if you are aware that someone was utilizing a substance, maybe it's 40 bags of nacho cheese Doritos that are empty laying on, I don't know what it is, 6 pizzas every shift, I'm not sure. But if you, I'm trying to make it a little bit light, but honestly, if you become aware of an issue, one of two ways, either you know that they have been smoking, you saw them doing it, or they mentioned it, you're concerned, I think you have to intervene. If you see, just back to her comment, if you sense impairment for some reason, you don't have to know what the substance is. You need to intervene and check that out. But it is going to be more difficult, I think, with that particular substance and legalization about whether that's impairment or not. Here's a corollary right back to you. I got a question the other day, and it's a really good one. Okay, a doc had multiple surgeries and is coming back to work, but in order to manage his pain, he's on 2 Percocet every 4 hours. Is he impaired? No, not necessarily. So if they're doing it legally, and you're monitoring it, they should report it to you. I'm using this while at work. Okay, let's make sure you're not impaired, and then we monitor you. I think it's okay. You would be amazed at the number of people driving around the roads every day that are on opioids, and they're not really impaired, they're just managing their pain. So I think we can, where I see this going is we will handle it the same way, but I don't think we have our arms firmly around this issue.
My other follow-up question, and some of it you kind of touched on already, but for the medical staff, a lot of times they already have an impaired physician policy. So obviously as a group you could go above and beyond that, but would you find that a sufficient policy to use, or at least a starting spot? I think, good point, and I think any policy that you draft or develop should be in collaboration and conjunction with your hospital medical staff and their policy. You don't want it to be in conflict, but you certainly want to make sure that you're doing what you're supposed to, because oftentimes they won't go into the kind of detail that you'll need to say, well, this is when I'm going to intervene, and then protect yourself by having that policy. So you could have more specifics. And I really think operationally you need to have these other items in place, which may be a group. If you're hospital employed, it's one thing. But if you're a group where there's one contract or it's a bunch of contracts, then you need to deal with this from an employment standpoint. And that's why you need a separate policy if that's the case. And then my final question comes back to the concept of impairment. So you have a person who been reported to you as the medical director, suspicion for impairment. It would seem to me the timing of that sampling, both of blood or hair or whatever, would be very important, because I'm not sure how hair, actually tells you that they had acute impairment. Hair might tell you the history of use of something or some other thing, but it may not describe an impairment. So Do you think timing is important for that situation?
I think timing is important, but not critical. I think no matter what mechanism you look at, if you find a substance, then fine, you've got your answer. It doesn't matter. Okay, well, I do that substance, and it was in my system, but I wasn't doing it that day is not really a reasonable argument from the provider. It's done at that point. The mental health professional is also very important, as I mentioned, because they may require another drug screen down the road. It's like, you know what, maybe it wasn't detected here, but I suspect this. And I think this person's at high risk. I want another drug screen, in 7 days or something. I don't know. So it's not perfect, but I think it really helps to guide us in these decision-making processes. And when we find nothing, and then we go ahead and put them back in the workforce and we monitor. But I think we have to do our due diligence with the best tools that we have. That's the best we have today. Thanks for the question.
Kevin, this is a two-part question. One, in terms of, you mentioned the increased number of medical students graduating and not enough residency slots for them. What are some of the innovative programs that are out there to address this need? You talked about it, but I didn't really hear a solution. We're going to keep turning out more medical students and having not enough slots. Anything for some of the big groups, funding residency programs or anything along those lines? And second question that ties in, with the combination of the osteopathic and the allopathic emergency medicine residencies, where are we going to end up lengthwise? 3 years, 4 years, 5 years?
Yeah, I can speculate on some of those thoughts. First of all, the ACGME AOA merger. There's ongoing discussion about that, and I would certainly not profess that I'm any expert in what's happened with that. I believe that it will probably migrate toward the shorter time frame, not necessarily the 4-year, but whether the traditional rotating internship will be maintained that the AOA has maintained for a long time, and some people choose to do in ACGME programs. I think it's going to be an option, but not a requirement. That would be my best guess at this point. As far as programs out there to say, how are we going to remedy the issue of graduating more student doctors than we have residency slots? Well, we have a regulatory issue, number one, that we have to deal with. And even if a group were to fund, or an individual were to fund a residency training program, they could do it. That would add a few slots. But there's not going to be federal funding for that. And so you still run into those roadblocks. So I think where we are today, as I see it, that we have recognition of this issue. Now the next step is, what are the solutions? Clearly, we continue to think, not we, but collectively in legislators and others, that if we turn out more doctors, we will fill more slots. They don't understand that graduating from medical school, you're not ready to practice any specialty most of the time, so you're going to need formal training, and we've got to provide those opportunities too. I have not heard specific solutions. I may not be the best one to answer that. Maybe Nick was going to think he could probably address that particular question. Thank you.
Thanks. I'll put on my academic chair hat. The reason why this is so big today is that just in the last year or two, we've actually crossed the threshold where the 1997 ruling has really come into effect. There are graduates who cannot, of U.S. medical schools, who cannot get a training program, let alone a training program what they want. And I got to tell you, I dread this match day, which is coming up in a couple weeks, because I'm going to get a call from the dean. What are you going to do about this? And I say, well, I'll vote out everyone in Congress. Sure, we'll change it. There are some really good people who have graduated from medical schools where I've been affiliated who did not get places, and they are not working as greeters at Walmart, but they're similarly having difficulty getting employment. In terms of what to do about it, there has been a task force, a joint task force between ACEP, SAM, EMRA, CORD, and the academic chairs. It's met for the last few years. I'm the academic chair rep to that task force, and we've been looking for alternatives for funding, and that group will meet again in New Orleans at the SAM meeting. Some of the creative solutions, some people have gone out and asked large groups to sponsor residency. There are a few states that have sponsored extra residencies. The VA has sponsored some residency programs. So there are some issues out there where people are trying to address this on an individual basis, but as Kevin says, that's good for a spot or two here or there. That doesn't solve the problem. Congress, CMS through Congress, have to address this directly. Now, I would think, and this is my ask here, I would think that large groups like MCare or Team Health would want to sponsor a residency program. And I can tell you from an academic chair point of view, if somebody came to me and said, hey, we're going to give you some money to have more residents, I would say, thank you very much. When can we start? I think that from a business point of view, that may be in the interest of some of the people in this room and the emergency medicine community to fund our own residency spots. My program director did an RFP, and residents are pretty good return on investment. So you can get a lot of mileage out of teaching residents, and they do a really, really good job. And I think that's something this industry may need to look into to expand residency programs.
Nick, my group is a 5-hospital group. We're very small, and we sponsor, I think, 2 residency positions at the University of Utah. So I think that model is out there. And remember, that's how many emergency medicine residencies began, was really at the community level where a group would actually start some training efforts.
Yeah, truth be told, when I was a resident, we sponsored several of the residency slots by covering the psych floor at night. So you'd have to go up there and any medical problems, and some of the residents would complain and say, okay, we don't want to do that. And I trained under Peter Rosen, and Peter's response was, okay, which one of these leaving tomorrow, because we can't pay for it. So that stopped the complaint.
In the East, hospitals are well over their cap. The Partners healthcare system, Brigham and Women's MGH, is hundreds over their cap. The hospitals are paying for it themselves. In New York City, many of the hospitals are well over their cap. Very straightforward reason. Even in these unionized environments, and the House officers are unionized, in the hours capped through ACGME environment, it's cheap labor. It allows one hospitalist to cover many more patients because the residents do the primary work.
Anybody got any operational problems that they're struggling with? We talk about what gets the CEO up at night or keeps them up all night. What bugs you? What causes you sleepless nights? Anybody have any questions they want to put to the room at large or to our panel up front? Or if anyone wants to do a little tail wagging because you're doing something kind of new and innovative, we'd love to hear that as well.
Okay, I'm not sure who on the panel would want to take this question, but one of the things I appreciate about EDBA is the volume cohorting that you provide. But the challenge we're seeing more and more, I don't know if this is because ED CAPS is coming, but now all of a sudden this year, our C-suite has said, well, thank you for performing well in your own cohort over the years, but now we want you to perform against the best we see out there. In other words, if we have 70,000 ED, 110,000 ED, now they're looking across all the data and they're saying, we want you to beat the 20,000 visit places. And even in Prescaney, they're saying, no need to compare your 100,000 visit ED to the 70 and 100,000 Prescaney cohort. Now we're going to compare you to the all Prescaney cohort. We want you to be in the top decile against that. Any words of wisdom on how you address that challenge?
Did they say open the checkbook? That they were ready to spend money?
Surprisingly, no.
Because operatively, they some EDs have said the 250,000 visit ED in Florida has said we operate 12 pods, so we have 12 20,000 volume emergency departments that shrink down at night, but conceptually we do that. Now, even 12 20,000s can't operate a 250 grand ED at the same levels. Your hospital, if they want to commit to that, they're welcome to. Imagine this, think through this. What if the federal government said, unless you can prove that you can operate like an under 40,000 ED, you're not allowed to see over 40,000 patients a year? That would be significant. And again, this is a significant money issue. It relates to staffing, to backup, to taking care of boarding issues, to taking care of EMS arrival issues, et cetera, physical design space, processes, et cetera. It would cost uncounted amounts of dollars to get a 100,000 visit ED to operate like a 20,000. I'm sorry, that's what it would take.
Have any of you had any success in getting patients, boarded patients, moved up to the floor as hallway bed patients or otherwise? I understand some places have, and my standard line I tell the CEO is, why is my hallway better than the hallway of the inpatient floor? They have the Pyxis set up for it. The medications are on the floor. They have fewer med errors in these patients than we do. Looking for some words of wisdom to take back to the C-suite.
The person who's done the most of this is Peter Vicellio. Peter was here at the conference last year and gave their data, the Stony Brook experience. I've been trying for years to push for that. The biggest pushback has come from my chief nurses officer, who says between no and hell no and hell no. But you're absolutely right. A hallway's a hallway's a hallway. And we had, when I was on the ASAP board, we had, everyone says it's the Joint Commission, it's this, it's that. We actually had dinner in a presentation by the president of the Joint Commission and said, how come our hallway is one way and the hallway upstairs is sacrosanct? And the response is, according to the Joint Commission, it is not. A hallway's a hallway's a hallway. So if you do have patients in your hallway, and we all do, it is the equivalent from the Joint Commission and CMS that they can be in the hallways upstairs. You just have to get the political buy-in. And you gave the thing yesterday? Who? I can't remember. Somebody gave the example. Dave did. Seberg, that's right. Dave Seberg gave the, I know I get the two of you confused. Usually at 3 in the morning when we're out, but still. But you have to get the political buy-in locally. And they have done that at Stony Brook, and Peter is very good about sharing how they did that. We cannot get it at our shop.
Let me go back a few years, but the CEO at the hospital where I trained and was serving early on was Miami Valley Hospital in Dayton, Ohio. The CEO of that hospital knew that the ED rescued that hospital. And the CEO was personally committed and had his C-suite team at the time personally committed to the ED would be open. When they began to run into boarding issues, do you know what secret little thing they did? They sent the volunteers from the hospital up on the floors to spy, to see and record what were open beds on the floors. And then the CEO or CNO would go up and say, why isn't this bed in the tracking system open? That CEO on Mondays when we were busy, the CEO, the CNO, and the COO were in the emergency department helping us push beds around or whatever was needed. And they never found, even though supposedly they were going upstairs, and Peter talks the story too, they've never gone upstairs and actually gone into the hallway. Magically, the bed opens up, and Vicellio tells the story much better, but there's a magic portion of pushing a bed upstairs that magically a bed opens up on the unit where you're going. And the patient is pushed in there because the upstairs staff, and I told you about the L&D staff yesterday, think we're barbaric by treating people in the hallway. They would not consider that in any way their part of care. And apparently the upstairs staff has some flex and beds open up when patients are to be pushed up there that supposedly were assigned to a hallway upstairs. So with those kind of background issues, I don't think anybody in the room can come up with a single way to address this, but personal commitment from the CEO goes a long way, and the commitment of all kinds of spying mechanisms to find open beds helps a lot.
I know we've been talking about this for a few minutes, but three points I'd like to leave you with too. The fire marshal issue, it doesn't exist, and the concern that they raise about this being a safety issue from a fire safety standpoint is created currently in your emergency department. So that doesn't hold water at all. The fire marshal probably, if you call them and say, I haven't been over there in a long time, can you give me directions? It's not a fire marshal issue. The fire marshal issue would be what's happening with the congestion in your emergency department at this point. If you look at, I think it was the series of 3 articles that Peter published, a couple things have always stuck in my mind. That when you put people up on the floor upstairs, their experience of care scores go up, not down. They go up. And also, what is the likelihood of decompensation requiring a higher level of care, such as to the intensive care unit? It is not increased by using hallway beds on the floor. Those are oftentimes arguments that come up that Peter very, very eloquently addressed in those articles, but I think it's the first article, then there were 2 follow-up articles. The final one was based on experience of care. This does not negatively impact anything except it increases the workload of oftentimes of the floor when they're able to modulate their volume by saying no, or we aren't able to modulate our volumes in the ED because of this thing called EMTALA. But I love Jim's perspective. Wouldn't it be great? Yeah, if the federal government said you can't see any more above 40,000, that is the best EMTALA reform platform I've ever heard. So more power to you. All right, thanks.
Thanks, Kevin. Hey, folks, I hate to do this. I'm going to allow one more question, and this lady already nabbed it. And I'm sorry, I've got to be the conference Nazi because you have your workshops to get to, and my people in the back are heckling me a little bit. But remember, we have 2 more open forums. Tomorrow we have one in the morning that's about freestandings and alternative cares, places to get care, and then we have another open forum in the afternoon. So here's our last question, and boy, this was great. Wasn't it fun? Did y'all have fun? I had fun.
Thanks. I think this is going to be directed towards Nick, just because I see you're giving the lecture on the freestanding EDs. So for those of us who are in the certificate of need state, like Ohio, are the freestanding emergency departments that are hospital sponsored, are they falling under that regulation that you have to approve certificate of need? Because it certainly doesn't seem that way.
And by the way, Jess and I live about 3 minutes apart from each other. I don't know the answer to that. I'll ask Tim, my CEO, how we started ours, because I have no idea. All I know is I was given a date and be ready for an open. Okay. I don't know.